Hello and welcome. This is Dr. Divyam Goswami along with my dear friend Dr. Bhavya Bansali, and we are hosting this wonderful DiGo Talks session. And our today's guest is Dr. Julie Symes Phillip, who is a fellow of Royal Australian and New Zealand College of Psychiatrists from Canberra, Australia. Welcome, Julie.
Thank you, Divyam, and thank you to you and Bahiva for hosting and putting DiGo Talks together. And this is a terrific opportunity. And today I'm actually speaking to you from a little town in New South Wales called Bombala. It's a town of 1,500 people. My mother lives here, and it's a place you can come to. It's got a beautiful river, and you can, if you're very lucky, see a platypus. But today I wanted to talk to you about the recent moral injury conference for first responders. It was held in Launceston in Tasmania in Australia. This was a really interesting conference, and I thought I'd give you a quick overview of the conference and then present what I presented to the conference, and then we could have some discussion afterwards. So it is a very bespoke talk because we're really narrowing down to an occupational group of first responders. So in Australia, that's anyone who's serving in uniform, and it's a little bit like the Canadian way of doing business. It's that concept of people who protect people. So Defence Force, Australian Defence Force or ADF, police forces, ambulance, fireys. So first responders is the context that this conference was about. So there were over 300 delegates at this conference, and there were people basically, it was quite local, so mostly from Australia. There were a few people from the UK, from New Zealand, from Canada. Somehow someone came from Belgium. And there were multiple disciplines represented here. So there was probably only half a dozen psychiatrists all up. The rest were a mix of GPs. There were a lot of faith-based presenters or chaplains or padres, and then the normal range of allied health that you have working in mental health, social workers, clinical psychologists, sociologists, those sort of people. So really the interest in this conference has come around from the recent addition into the Z codes of moral being added to the section on problems related to psychosocial circumstances. And this has generated, I suppose, a huge amount of excitement because all of a sudden we're talking about a moral dimension in the classification of a psychiatric problem. So there was a lot of, I think, both interest and confusion being generated about moral coming into and moral injury coming in as part of the DSM as a Z code. And as we might understand as psychiatrists, that a Z code is a contextual understanding of a diagnosis rather than an actual diagnosis. There's been a groundswell of, I suppose, movement and energy around whether or not moral injury in of itself should become a diagnosis. And so the frame of a lot of the medical staff at the conference was really around that's probably not going to be a helpful approach in terms of a recovery trajectory for our patients. So I'll just talk a little bit about me. That's me, the old bat in the picture. So I've had a very winding journey to becoming a psychiatrist. Obviously, I'm an older person, but my journey, I'm still a relatively junior fellow. It's only I'm only sort of halfway through my second year of fellowship. So I started out in the 1980s. I was a soldier in Norforce, and that's our regional Northern Australia surveillance unit. So Alice Springs, Darwin, Nhulunbuy, really based around a very heavy First Nations integration of trackers and obviously providing northern surveillance to our borders because we're a very big continent with not very many people. So from Norforce, I went to Duntroon, the Royal Military College, and did my general officer training there and had a posting to the Middle East and came back a little bit settled. By this stage, it was early 2000s, and applied to do medicine, and I was sponsored through medicine by the Australian Army, which was wonderful for me because it provided a salary and it provided a pathway to going on to work as a clinician back to our uniformed personnel in the army. And it was through that job that I got interested in mental health and interested in psychiatry. So I didn't start out doing medicine thinking I was going to be a psychiatrist. I was on a rural and remote GP pathway. But there just was a lot of mental health issues starting to present at that stage. So as part of my training, and I know I have a lot of colleagues who've come from India. I've never travelled in India, and I do hope to one day. But a lot of my colleagues from India have already done a lot of training before they come to Australia and do another fellowship. So they already have a lovely wealth of experience as clinicians and as doctors. And as part of that training, I'm sure it's very similar in India, there's a mix of public and private experiences. So I did most of my training in our public hospitals. Our training is a minimum of 5 years, and every 6 months you're essentially changing role. And since I graduated, I was asked to stand up a ward in a private hospital in Canberra for first responders. So it was only a 12-bed ward, just a small ward. And I did that for essentially just over a year, and really started to, I suppose, have the sense that the model of care in this particular cohort group is not quite right. Most of the people that had a diagnosis of PTSD and were sitting on an inpatient ward actually didn't clinically meet the criteria for PTSD. Probably up to 80% of the patients I had under my care at that time, they definitely had psychosocial stressors. They definitely had, a few of them had what we'd call in the old days Axis 1 diagnoses. So they did need psychiatric input and pharmacological solutions to that. But they didn't really meet criteria from PTSD in a strict DSM sense, which I suppose really led me to start wondering about what is the right approach for PTSD and what is the right approach for people who think they've got PTSD and have experienced trauma, but do also need to continue to recover in their lives. Now, this space gets really complex in Australia because, especially working with military veterans, we have a very generous Veterans Entitlement Act. So we have people who have compensation for essentially becoming unable to work. And as you can imagine, there can be a lot of potential secondary gain around government employment allowances by remaining broken. So we almost can get into the stage where recovery stops being a focus in our work as clinicians. So I've done a lot of sort of work popping in between public and private. Our public wards, which would be the same, I imagine, all around the world and certainly post-COVID. And for some reason, Australians are very high users of illicit substances. We have one of the highest rates of methamphetamine use in the world. So a lot of our public beds are really busy with people having acute psychosis, which often settles down when they're no longer under the influence of illicit substances. So I've been to sort of working in communities like up in far north Queensland, Cape York. We're doing some fly in, fly out work from Thursday Island into the Coral Sea, over to Western Australia and Bunbury. So sort of, really been formulating for a while what is the right approach from a trauma. People have experienced trauma and want to move on in their lives. And one of the big things, and I'm sure this is a universal experience, is that developmental trauma is incredibly common. Not many people have the blessing of a family that gives them a good sense of themselves and gives them a good way of self-formulating the kind of life they're going to have as young adults. So there's a lot of people out there walking around with attachment injuries and quite maladaptive, trauma-informed personality vulnerabilities, and that they often will internalise some quite narrow and quite unhelpful ways of being able to move forward in their lives. And certainly, this again, I'm speaking very much in an Australian context, there's a lot of people who put on uniforms are people who have been parentified at a young age. They often have a higher rate of developmental trauma. And so they're coming into a uniformed role, not as a clean-skinned person, so to speak. And certainly once you join the military, and again, I'm sure this is universal no matter what uniform you're which country you're serving, is that there's a transition into being in uniform, which almost halts a lot of adult milestones. And if we think about Erickson's psychosocial stages of development, coming into the military where you're,
Excuse me, Julie.
yeah,
Are you changing the slides?
no, I'm talking about reflections.
Okay, 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 no
Are
problem.
you on back? Are you still on background?
Yes, I'm on background.
Yeah, we're still there.
Okay, okay,
I'm just talking a lot.
okay,
Um,
no problem,
so,
no.
so, so just talking about that second last point now about identity transitions. So, especially around recovery and purpose. So, in the defence force, people's identities tend to be halted almost in that adolescent stage. You're told where to live. You're told how to dress. You're given a uniform. You're told how to cut your hair, how to wear your beard, what makeup you can wear. It's very, very regimented, which is very helpful for people in terms of belonging to a cultural identity that's uniform and but not very helpful for becoming an adult and developing some autonomy and some self-agency. So often when people have to eventually transition out of uniform, which is inevitable as we get older. I mean, if you're a soldier and you've got to serve as an infantryman and you've got to carry 40, 50 kilograms on your back day in, day out because ammunition weighs what it weighs, a pack weighs what it weighs, you're not going to be able to do that to you in your 50s and 60s and 70s. So there's an inevitable conclusion to your service, and which is, I suppose, different to a lot of other roles and identities. And what you get for a lot of people that are transitioning out is that real difficulty where they start to reflect on the energy that they've given to these organisations, and now they can become quite bitter about it. And I think there's a lot of, and this is a general issue for psychiatry, and those of you who've doctored in other areas, if when you're doctoring in other areas, orthopedics or surgery, or even in a lot of your GP roles, there's a lot less shades of grey to work with as a clinician. Diagnostically, your tools are a little bit easier, I suppose, to interpret. You can interpret an MRI, you can interpret an X-ray. And psychiatry is a lot trickier, because we're doing a lot of interpretations on what we observe or our skill set and what our patients are able to tell us. So I think what happens when we start talking about PTSD and moral injury, and there's a lot of psychopathology that people will self-report and magnify and can be very difficult for more junior clinicians to challenge. So just wanted to reiterate that the views that I'm talking about and the opinions are purely my own. I'm not representing an organisation. I'm not speaking on behalf of any organisations. These are really my own thoughts, I suppose, and my own clinical experience from the roles that I've been in. I did want to formally acknowledge, though, all the first responders I have worked with, and the cases I'll present later today. Everybody has given consent. They are de-identified, but people have given consent for their cases to be presented. I just wanted to draw your attention to this quote that, and again, this is starting to be, I suppose, an international experience, is that while there's a lot more awareness and probably less stigmatisation for a lot of mental illnesses and injuries, really the rates have not reduced too much. We're still having the same rough percentages of people presenting with psychosis, with completed suicides, so, and the dropout rates for what is considered gold standard in the trauma treatment rate is pretty consistent, up to sort of 30 to 40% of first responders tend to drop out of trauma-informed talking therapies. So one of the big things that came out of this conference was almost this sort of false dichotomy between moral injury versus PTSD. Now, I think, there were all sorts of various definitions that were presented at this conference, and I'm going to just read out for you the Australian Defence Force definition of moral injury. Moral injury is a trauma-related syndrome caused by physical, psychological, social, and spiritual impacts resulting from grievous moral transgressions or violations of deeply held moral beliefs or ethical standards. And I hope I hope everyone's sort of feeling a bit curious about that, because obviously these are incredibly subjective definitions, and there was quite a few presentations around the different spectrums and scales that moral problems can occur across, initially from a safety, then through to moral stressors, moral frustrations, moral dilemmas, and then distress and trauma, and eventually people developing moral injury disorder. Now, moral problems, I suppose, and it doesn't matter what time or cultural era that we live in, the ancient Greeks were writing about these problems. All of the major religions in the world are really about trying to organise from a faith-based perspective the way that we live as a good and a moral society. And I suppose it got me thinking about PTSD, and those of you who have spent a lot of time working in the PTSD space will know that even defining trauma can be incredibly difficult. And if you look between the various reiterations of the DSM, starting really from DSM-3, DSM-4, 5, and the current edition, and there's already talk about what DSM-6 is going to look like. Just also noting that DSM is the one that tends to be used more in Australia than ICD. ICD gets used for hospital coding, but the college, the RANZCP and DVA and a lot of the bigger institutions tend to use the DSM in its way of diagnosing and applying compensation review. But even defining trauma is very complex. And there was a presenter who talked about us living in a morally injurious era, and that there are all these sort of geopolitical influences that are making it very difficult for people to find a good, clean way, I suppose, of living, and talking about world war events and the harming and killing of civilians and, weapons of mass destruction. In Australia, there's a lot of issues with recurrent bushfires and towns being able to be sort of, I suppose, destroyed and have to be rehyped and COVID was a worldwide phenomenon. I mean, I had some friends who were nurses in Australia who'd sent their little toddler back to grandparents in India because they were awaiting the birth of their second child, and then the borders closed and they were unable to see their child for 2 years until the borders sort of opened again, and just how incredibly stressful that was for the young family. Social policies such as how domestic violence is handled, human rights in general. So where do you sort of stop if you want to start thinking about PTSD and defining it at an individual or a social level? And the other issue for us, and we all know this as psychiatrists, is that the way the DSM is set up, and it wasn't meant to be a diagnostic manual in terms of a clear black and white clinical directive, but it's often how it is used. But it's a polyphyletic system. You don't need every symptom to attract a diagnosis, and to attract a diagnosis of PTSD, someone's calculated there's literally hundreds of thousands of different unique combinations that can eventually result in the same diagnosis. So if we think about subjectivity versus objectivity, and I had a presenter who's a good friend of mine, Dr. Peter Wheatley, and he was a young captain medical officer at the Rwanda genocide. Now, I hadn't sort of known much about Rwanda. I've never served in Africa, and he talked about this sort of the numbers were just astonishing. 800,000 to 1 million people dead in 100 days. Low tech manualized violence, use of machetes was very common. It was a very hands-on, very graphic, closely done, and the impact on the United Nations troops and forces. And I know in India, you've had, there's been constant conflict along your borders, and often the aftermath of managing that. And again, I'm very ignorant about how that's managed in your defence force, but one person's trauma is another person's day on the job, and certainly most people in medicine at some stage will be in work situations where you are traumatized, it almost, I think, for most doctors, it becomes part of handling yourself professionally. And there's a big concern, and I think in the medical world and certainly in the psychiatry world, that the enthusiasm for moral injury being a standalone considered diagnosis is far outweighing any scientific or evidence-based knowledge around how this should be incorporated. This was just a quote that sort of someone gave around Nancy Sherman. She's an American author, so, obviously a different perspective. But just about, I suppose, the fact that when you've been through something unusual, it's going to affect you from a perspective of psychologically dealing and reflecting on that. And oftentimes that's not going to happen while you're part of that workforce. So I just want to come back to treatment approaches that I've sort of, I suppose, in the PTSD space. And this is talking about people who've been referred from a GP, which is the standard approach in Australia. You don't get to see a medical specialist until you've gone through your general medical practitioner first. And that's the way that funding and Medicare approaches things. But when someone's needing inpatient care or needing a psychiatrist, there's often other imperatives that need much more attention. The most common thing I have seen as a specialist is the lack of a good physiological workup by other doctors before someone approaches you. So, for example, we know a lot of PTSD manifestations are very somatic. Surely it makes sense to approach someone from a physiological workup to make sure there's nothing else going on to explain their symptoms. I mean, if someone's got, erratic heart rate, or they've got blood pressure that keeps spiking, you need to do your basic screening. You need an ECG done. You need a good pathology workup. My approach tends to be, if you bleed them once, bleed them for everything. CDT is something that I use a lot because as alcohol misuse is so common in the PTSD space. I mean, people drink alcohol because it reduces their hyperarousability. They don't drink it because they're stupid. They drink it because it's doing something for them. Alcohol's cheap, it's accessible. In Australia, it still tends to be a very pro-alcohol use culture. CDT just wastes a lot of time. Carbonase dehydrogenase, transaminase. So just a quick blood test, and it gives you almost a HbA1c approach in that how much alcohol that person has been processing in the last couple of weeks before they saw you. Just the basics, like, doing good set of observations and making sure your nursing staff know to do a sitting, standing blood pressure. Make sure, people are sleeping appropriately. If someone's got sleep apnea that's untreated and undiagnosed, there's no point us prescribing Z drugs, for example, to manage their insomnia. I think it was just really more trying to focus the fact that, we like to think we're the cause of our patients' recoveries, but people's lives happen outside of our offices, and they certainly happen outside of our hospitals. The other thing you'd see you get a lot of in this space is that sort of interplay between traumatic brain injuries, especially where it's been sort of low-level blast exposures, and people having a diagnosis of treatment-resistant PTSD, and that leading them to go on to do some sort of often emerging very expensive therapies, such as ketamine infusions or psychedelic assisted therapy is a new emerging therapy that's been funded by DVA. But often when you go back and unpack someone's treatment history, they've haven't had good, sustained, simple treatment approaches. They haven't had decent pharmacological range of trials across different medication classes. Cerebral perfusion, I think, is really important in the space where people have had early cerebral insults, because, we can understand if someone's got hypoperfused frontal lobes on their SPECT scan, they're not going to probably respond well to the talking therapies. And that's not to say there's a lot that can't be done in an office-based treatment, and it doesn't have to be done by a doctor. If you've got a good allied health clinician, they can run group therapy. They can engage in EMDR training one-on-one. You can teach people to do their own EMDR. I don't know if hypnosis is a treatment modality used much in India, but I know there's been interest and curiosity about whether or not some of the non-big pharma treatments can actually have a sustained recovery. So it was really just a reminder to everyone, certainly in an Australian context, if you're referring someone to a specialist, make sure you don't embarrass yourself by your specialist having to tell you that your patient is hypothyroid, for example. So that was really just more, I suppose, a reminder. And I think it comes back to treatment dilemmas, I suppose. I just mentioned briefly about the cerebral scans. I mean, I'm amazed at the number of people where, we're dealing with someone with a hypoperfused frontal cortex, in which case we need to get them activated, which leads us to different medication choices, or it might lead us to some lifestyle therapy approaches where you're basically getting people activated from a movement perspective. Interoception and introspection, to sense and articulate one's internal state is a skill, and not everybody has that skill. And certainly in the first responder space, especially, people don't often have that as an assumed skill set. The recovery expectations, placebo is a real thing that can be exploited. As you as a practitioner, the first time you meet your patient, we're not trying to set up we want redundancy in our patients relying on us. We want them to be sacking us once they're owning their own recoveries. And I think that comes a lot down to perspective. So, and again, this I'm sure is a very universal experience. I mean, bureaucracies tend to behave as sociopaths. They're not there for the good of their individual workers. They're there to achieve a mission, be it for their shareholders or for their government or whatever, but their role is to keep people working for them as long as possible, which means that who is paying the bills for someone's medical treatment or medical recovery starts to be important. And I think a hallmark of recovery is you getting your patients to eventually neither eradicate their trauma memories or to avoid or to overreact to rigidly to reminders, but to place their service trauma in perspective and to regain control of their responses. And I think that really gets lost when people are trying to just focus in on a business model around where trauma is sitting in someone's psychiatric pathway. So I want to talk about some individual cases now. Again, as I said, these cases have all been de-identified, but people have given consent to talk about it. So first case is a 62-year-old gentleman, and he joined the Navy when he was 16 and a half years old. They used to have an apprentice system where people would come in and learn a trade. So they joined at a much younger age, and they were cohorted as young people. And this fellow, very unfortunately for him, did have him and another young chap was sort of selected out by a group of older men, and they were quite brutally sexually traumatized on a regular basis through their training. Didn't tell anyone. This was sort of back in the 70s that this occurred. And this gentleman had gone on from the surface to sort of having quite a productive life. He'd married, he'd had children, he had had a lot of problems with alcohol, but he'd managed to be promoted to the rank of sort of warrant officer, so quite high up. And then he'd left the Navy after 20 years of service and gone and joined the police force. So, he'd moved around a lot, had a lot of postings. And then the Defence Force brought out a inquiry called the DART, which was the Defence Abuse Response Task Force. It ran from 2012 to 2016, and it developed a couple of thousand cases of people who'd sort of put in experiences of gendered trauma in their service career, and they weeded through these cases and came up with about 1,700 cases that they thought were plausible, and this was related to claims for compensation. So again, they had to try and sort of sort out people who were essentially, I suppose, incorrectly claiming that things had happened to them. But it was a good example. And this guy eventually sort of really fell apart once this all became publicised, because it was that failure to disclose to anyone in his life what had happened. So he carried a lot of shame. It was male on male sexual trauma, which for him he felt was dirty and was shameful. He'd never told his wife what had happened to him. He'd never told his two sons what had happened to him. And it really had affected the way he was perceived in his marriage and in his role as a leader in his family, as a father. And so it was just sort of, I suppose, a good example of how long, and this guy did have actual PTSD, but how long trauma can sit and almost act like undrained pus in someone's psyche. It doesn't go anywhere. It bubbles along until it eventually does present. The second case is a fellow, 49 years old, really interesting guy. He joined the police force as an older chap in his 30s, which is a little bit unusual in policing services here. Before that, he'd worked in various roles, worked in the mines, worked and had a trade. So when he joined the police force, he was, a bit older than the average recruit, and he went to general duties and then eventually became a homicide detective. And over the course of about 10 years, just did a huge amount of attending completed suicides, death notifications to families, unusual murders and unusual deaths. And this guy started drinking quite early on in his career. And of course, each of these cumulative exposures just got more and more and more and more, until by the time he presented to his general practitioner, he was up to drinking 2 bottles of tequila a night, which is a huge amount of alcohol. And he was doing that to sort of, numb himself out, deal with the intrusiveness of some of his re-experiencing phenomena. But he hadn't told anyone how much he was drinking. He was working with a very good psychologist. So really, and this got picked up, the amount of his drinking. He had unusual changes on his liver function tests, and he had this real failure to disclose both his suicidal plans and his suicidal thinking and his drinking. So really the first approach for treating his PTSD was treating his alcohol use disorder. Last chap, much younger, he only did a couple of years in the army, and then he joined the Fireys and spent 20 years as a Fiery. As I'm sure you've seen on the news, bushfires are a big problem in Australia, often reaching sort of massive temperatures and scales of, you'll get fire fronts that are sort of kilometres wide and a couple of kilometres deep. They're really, really difficult fires to fight. And, sometimes there's been some awful, I'm sure you would have heard of the Ash Wednesday fires and the fires that swept down the south coast a few years ago. And certainly in Canberra, we had some loss of life with some big bushfires a few years ago. And this fellow really was going quite well with all these exposures he'd had, until he was promoted and had a lot of problems with rostering and managing that. And then he really developed these sort of real angst around his peers no longer accepting him because he was now a boss. So this was wasn't PTSD, it was more sort of moral injury around him not being able to cope with being a leader, and then blaming the organisation for what had happened to him. So again, he really needed a psychodynamic formulation rather than a pharmacological management of his symptoms. So clinical observations is, I think there's our role as therapists and our role of psychiatrists is not only to think about how we manage someone's physiology, but to think about how we formulate them from a psychodynamic perspective, and how we can help people to reframe themselves so that they can create some new horizons in their recovery and in their lives, go back to their families and resume those leadership roles they should be holding in the therapy. So what I do see a lot of in this space is not enough lifestyle changes. I mean, once someone, as we get into middle age, our bodies change and our energy levels change. And if you're not conscious of that and not mitigating against it, you can really fall into a hole. So clinical observations, this is obviously just a quick summary, is, keep it simple. We are basic. We need to be hydrated. We need enough food in our bellies. It really comes down to Maslow's needs, isn't it? It's hard to do anything particularly clever from a psychodynamic perspective if people are hungry and don't have a comfortable, safe, secure place to sleep with at night. So cautionary tales, I suppose, was about the fact that diagnoses carry their own baggage, and we all know this as psychiatrists. A lot of us are careful. For example, if you're dealing with a first episode psychosis, when do you label it schizophrenia because of the heavy loading that's going to carry forward into someone's life, but you need to treat their psychosis. I think moral injury, the textual consideration, this false dichotomy about moral injury or PTSD. And then we even had presenters that were, not doctors, but people talking about, well, if you treat someone's moral injury, their PTSD will go away. And, clearly not understanding that the actual clinical depth and the relationship that needed to be looked at. So I think one of the things we often don't call out is the command and control systems and bureaucracies that first responders work in. There's going to be an element of moral injury in any uniform. And I think most doctors have experienced this when you've had a busy shift at a very busy hospital, and you've only got a certain amount of beds to admit people to, and there's nearly always more patients than there are beds, and you're triaging and making decisions around who gets what. And that your decisions, your direct clinical care is going to be meaning that you're making a choice of who moves out. And you have to come to peace with that to be able to continue to be effective in your role as a clinical leader. And the same thing happens to scale with any bureaucracy that any of us work for. So I guess, at the end of the day, it's not about you. It's about understanding the systems you work in. Any bureaucracy has to eventually understand and behave almost as a sociopath to survive and to be able to continue to do its job. So our roles within a therapeutic relationship with our patients and with our clinical teams is around mitigating and understanding that. So I think the takeaway I was trying to do back in my world, we're working a lot heavily with the veteran population and first responders, is that conceptualizing distress does not make for recovery. Instead, we have to look to how can we elevate our patients' capacity for change, because change is what they need to own and take leadership with back into their own lives. And it's almost a reverse triage concept. We're not trying to do the least with the most, which is the way most medical businesses operate on. We're trying to do the most with the least, because that way we're going to have the greatest impact. The other thing I wanted to talk about was the concept of PTSD as being a fear-based response is not always the case, and certainly people who work with people with PTSD know this. Moral injury is a values-based response, and it's that false dichotomy and false security. We have to have medically led models in mental health for people to actually recover. And if people are not responding to our therapies, we need to reformulate and start again. Moral injury really are part of the human condition and have always been part of the condition. That's why no matter what culture we're from, there has been a way that societies have organised themselves as people to live well together, to have a set of values that we can all agree on. So the takeaway message I was really trying to promote is that focusing on moral injury as a separate standalone condition is just not a helpful thing to do. It doesn't promote recovery. It doesn't promote resilience. And it's not something we want to continue to give too much energy to. I really love this quote. I use it a lot in my work, and it's that sense of the jungle is neutral. Um, we're a tool to be used. When we put a uniform on, we're exchanging our labour to be part of something, part of the bigger picture. And really, as clinicians, we're doing a similar role. We're exchanging our time and our clinical thinking to help an individual or their families do their life differently. People are coming to us because they need help and they need support. There's an exchange of goods or time or labour or whatever it is. But we don't need more self-assessment tools or studies. We just need to do the basics right. And again, this is contextualised, obviously, to veterans in the first responder space. All right, so that's pretty much sort of what I wanted to cover off today. Really just encouraging everyone to, keep our formulations tight. Let's, when we're working with PTSD and with first responders, keep it simple, keep people recovery focused. And moral injury is an interesting concept, but let's keep it as a Z code and let it not become a standalone diagnosis. Thank you. I think we're curious about questions, or is there anyone who wants to make any comments from their own clinical experience or life?
Yeah, let me tell you, Julie, it was a wonderful presentation. It was amazing, especially the three cases that you presented. Gave us the real life scenarios that you depicted of moral injury. So I just wanted to ask if moral injury exists on a continuum with trauma or stressor.
I think that's a really good question. And certainly that was, I think people are actually trying to define that continuum. There was a lot of scales. There's been some various scales. In fact, I'll read a couple out to you where they've come up with a identifying moral injury and a self-assessment for moral injury based upon a moral injury event scale. And it is trying to identify as when is it a stressor and when does it actually come through to the extent of being a disorder. But it's just so subjective, Divyam. And I mean, it's that whole concept too of, two of us can stand shoulder to shoulder and watch the same event, and one person's terribly traumatized and the person standing next to you is able to keep on functioning. So I think this focus at the moment on moral injury is it's not a helpful focus for us as clinicians, and it's almost almost becoming like a competition between who can talk the loudest.
So do you need to screen share? I think we can close that now.
Okay. So, stop. Oh, sorry.
Stop sharing the screen.
Has that stopped?
Yeah.
Great. Good.
I also wanted to tell you that, I think Lana Barrett, if I'm right, she is working very closely with you. She is a clinical lead nurse, and she has joined our community. And
Oh,
when she joined the
lovely.
community,
Yeah.
yeah. So when she joined the community, she told me that she has been a veteran herself,
Mm-hmm.
and she has served in the Australian Defence Forces. And one thing that came to my mind was what German Field Marshal Rommel said about the Australian and New Zealand forces, that if I have to take hell, I will have the Australian soldiers do that and New Zealanders to hold it.
Yeah, that's great. That's terrific. Well, I think there's plenty of examples. In fact, I had worked with a gentleman when I was up in the Townsville homeless team, and he'd been a captain in the Indian Defence Force, and he told me some of his exploits. So I think you have the largest navy in the world. So I think India's got a very fine tradition of producing magnificent warriors as well.
Yeah, and what is uh, both common to India and Australia is the British foundations that we both have. And, I think India was the largest contributor in terms of soldiers to the British Army in the times of World War II.
That's correct. Yes. Yeah. It's interesting, isn't it, too? Because part of our national identity is often shaped by how we talk about our contributions to war, which is sort of sad, really, but true, true nonetheless. Yeah. And certainly, we're a very, very junior country here in Australia, and our immigration is what keeps us fresh and gives us our positivity moving forward into the 21st century. So I hope we continue to have that beautiful relationship with India. Mm.
Yeah. Uh, the next thing I wanted to ask is that what has been your personal experience regarding treating patients with PTSD or moral injury, where, as you said, that sometimes the general practitioners don't do enough and they just send the patient over to the specialist. So, what has been your personal experience regarding this?
I think, and look, general practitioners have a really difficult role because, the way Medicare is set up in Australia, it's very time-based, and often patients, by the time they're coming in for a medical review, have already got an amount of complexity coming into the picture. It was more the fact that we've had patients that have come to the ward that have come from other people's wards, where there just hasn't been, if you're going to hospitalise a patient and sit on them for 4 or 5 days, even sort of 24, 48, 72 hours, really you owe them the decency of some basic physiological screening. You should do an ECG, you should do a set of bloods. And if you're going to do a set of bloods, then you should think very broadly. We know what the somatic manifestations of PTSD are, but it's such a broad mimicker of many other physiological conditions. We know, for example, any sort of physiological insult that, the rate of post-MI depression, for example, myocardial infarct depression or post-stroke depression. So I think I hope it didn't come across as a criticism per se of GPs, but more a criticism of, look, if someone's under your care as a clinician, that the strength doctors bring to this is that we do have training in the physiological sciences, and that is a skill set that most of our allied health comrades do not have. So I think my message was more never stop being a doctor whether you're looking after PTSD or moral injury or schizophrenia or bipolar for that matter, because having a mental health diagnosis doesn't inoculate you against having other health diagnoses. Don't stop being doctors.
Yeah, that is a wonderful message. And, go back to the basics.
Yes. Yeah.
And the three cases that you presented, out of that, two cases had one word in common, and that word was shame. So,
Yes.
is that unique to moral injury? Because I think
No.
trauma is, yeah,
I agree, and I think one of the issues. So I'm just going to read to you again out the core symptoms of moral injury, and this is from a brochure that was produced by the Australian Defence Force, and these are the core symptoms of moral injury: shame, guilt, betrayal, anger, loss of trust in self, others, or transcendental entities, so people losing their faith, spiritual existential conflict, loss of meaning or purpose in life. And you're right, shame is, I mean, we've all had patients with schizophrenia or bipolar whose recurrent mania or behaviour when they're manic becomes a core part of their identity. And in fact, it's shame that lead people often to have a completed or attempted suicide. So I think there's a real danger at the moment of quarantining shame as being part of a moral injury spectrum, whereas in fact, shame is probably a universal symptom of someone psychologically not traveling very well. And that has been, I think, a real problem that we saw at this moral injury inaugural conference. I mean, this was, over 300 delegates for the first time a conference has ever come together. That's a lot of people spending a lot of money and time to come together to talk about something which essentially we all know. We're all working with this anyway. I think quarantining it off as a separate area is just not recovery focused. It's I mean, if you think about what Z codes are for us as clinicians, that they're concepts to help us conceptualize someone's diagnoses. Homelessness is a Z code, poverty is a Z code. We're not saying you've got a diagnosis of poverty, but yet we've got people trying to say you need to have a diagnosis of moral injury. It's not recovery focused. Yeah.
Yeah. So, getting to the recovery part and not diving much into the diagnosis or the semantic part.
Yeah.
So, irrespective of whether it is a moral injury or whether you label a person with moral injury or not, what would be the treatment approach and how do you focus on the recovery part?
Yeah, that's a really good question. And I think what muddies the waters a lot, certainly in the first responder space, is that, there's a lot of people who've set up businesses around their particular treatment approach. And often those treatment approaches involve other sort of complicated or emerging therapy pathways. I mean, I personally think you shouldn't be offering, there's almost that sort of medically prescribed addiction pathways where, people are having years and years of, for example, IV ketamine. Now, I'm not saying IV ketamine in of itself is not a helpful treatment or therapy modality, but if you've got a business and that's what your focus is, and you haven't done the other basic things like get people activated in their lives, just about anyone can benefit from regular movement. Just about everyone can benefit from good nutrition, eating healthily, cutting back on substances. If you haven't addressed those things first, throwing someone through an expensive treatment modality is to me just lazy treatment. So I think recovery has to be simple and it has to be repeatable in the person's life who's presenting in front of you. It really is about making it bespoke, not to your business, but to the person's life.
Yeah, and a lot of it has to do with what I started with, and the DiGo Talks community actually started with the longevity, because at that time I was not in psychiatry. I had not started my psychiatry residency, but I had authored a book on longevity in 2023, and there.
Okay. I'll track that down, Divyam, because I think this is really, this interplay now between wellness and longevity and psychiatry is actually really powerful.
Yeah.
If we're formulating someone who lives a good long life is going to be healthy from a psychodynamic perspective. And if they're not, because they've had a lot of family of origin trauma, we've got lots and lots of studies out there to show your longevity is impacted by your mind frame, by your capacity to experience awe, by your gut brain biome, so that's wonderful. You've got that background, so you'll inherently understand that need to get the basics right.
Yeah, and famously we say that exercise is as good as antidepressant, and there's a famous study
Yeah. Yeah.
to to prove that.
Yes. Listen, There's a really good, there's the Australasian College of Lifestyle Medicine has sort of 6 pillars around health and that concept of nature prescribing and prescribing exercise and prescribing movement. And certainly in psychiatry now, the deprescribing, Maudsley's now put out a textbook on deprescribing, and that's happened very, very quickly. So I think this is a real growth area. And in fact, the wellness, there's some international wellness conference in Thailand in November, and they were quoting figures like the wellness industry worldwide's worth literally trillions of dollars. So it's fascinating in a way because we're kind of all slowly coming together, aren't we? And certainly I use a lot of pharmacogenetic screening in practice because while it doesn't tell us about side effects or efficacy, I think it's very helpful to know what kind of metabolizer someone is because it helps you make good medication choices. And certainly the range of what we can tell, there's a lot of labs and businesses coming out now where with a blood test, there's all sorts of things we can tell you about your DNA and your tendency to recover and your vulnerabilities from a physiological perspective. I think this is a really exciting time to be a psychiatrist because we are in a good position to pull this all together. I'll have to hunt down
Yeah,
your
to
longevity
know
book,
that.
Divyam.
Yes. Although you can have a read, but I think it's 2 or 3 years old now, so a lot of things may be obsolete. So I'm planning
Be on
to bring
Amazon.
in a new edition next year.
Ah,
Yes,
excellent.
it's on
You'll
Amazon.
have you'll have to launch it through DiGo.
Yeah. And, I also wanted to ask you about the shame. And as you have said, that shame is not unique to moral injury,
No.
but it forms a core symptom of moral injury. And
Mm.
we have in the DiGo Talks community one of our members, Dr. Lisa Itherson, and she has actually conceptualized the therapy called the shame containment therapy. So
Oh, okay. Okay, I must look at that. Shame containment therapy.
yeah. So
Mm.
I would like to ask that how do you address shame in
Yeah.
your practice when you encounter such patients with moral injury?
Look, it's a tricky area, and again, you have to be quite careful with this because sometimes you pull the lid off a can of worms, and then you just get another lid, and then you just get another lid. Um, so, so the first thing I suppose is that cautionary tale of not rushing in. You have to have a good therapeutic alliance before you start wading in someone's shame because if you identify it and it emerges, it has to go somewhere. And shame is for those of us who have been parents, that 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 concept of shame is a way that toddlers grow into children. That transition. If a young person can't feel shame, that's a indicator often of more significant pathology. So I suppose articulating that shame is a common emotion is often helpful. So, the recognition of the events, like the first case I talked about, I mean, it was many sessions before this man was able to disclose what had happened to him because he still felt dirty, he felt contaminated. Now he fought hard so back at his first assault, his jaw was broken, but he felt like he hadn't done enough. And I mean, he was 16, he had two older men sort of holding him down and his body was violated. And gendered violence or any kind of intimate body violence always has a component of shame. We've all worked with patients where this is unfortunately not an uncommon part of their childhood. Shame is tricky to deal with because it's dense and it's often sitting in someone's limbic system. So, what I find as a treatment approach, you have to give them skill sets before you start talking about it. You have to teach your patients how to deal with however their physiology appears when it's distressed. So if they hyperventilate, they need to have good exercises for their box breathing, for example, or trauma tapping, or something that resets their vagus nerve, so you have to get that skill set in place before you go into the talking side of it. That's what I was sort of trying to talk about, that top-down approach. Don't do it back to front. Don't do the talking and then try and help them deal with the distress. Give them the distress signals first. Find which PRM medications are helpful, because most people do find the PRM medications really helpful. That is definitely I think there's a real danger at the moment with deprescribing going too far. People have got to be ready for deprescribing, and they've got to have a good trust in the treatment team around them. So skills to help with the physiological symptoms of shame, a good frame of therapy already established that as a therapist you can commit to. There's no point bringing out someone's shame and then you've gone on long service leave for 6 months. You have to walk on that journey with your patients, and you've both got to be committed to the process. So establishing the frame of therapy, and then normalizing the fact that shame is a common response. It's not them that's broken, it's them that has survived a broken situation.
Yeah, and I'm also planning to have Lisa Etherson on our DiGo Talks webinar. So maybe in June, we'll have her speaking on the shame containment therapy. As a pioneer herself, she would be able to throw some good light on shame. And I think we also touched upon this concept of shame in suicidology when we had our DiGo Talks with Professor Konrad Michel. And I confirmed with him that, shame plays a part in suicide as well.
Yes, absolutely. Absolutely. So it's incredibly caustic. And that's what I talk about with my patients. I call it undrained pus. Pus doesn't go anywhere, and we've all played with ulcers. You have to heal an ulcer from the base up. You can't just put a band-aid on top of it and hope it will go away. It's a painful recovery. You've got to scoop out that pus and then, have the ulcer heal with primary intention. So it's sort of a psychological ulcer,
Yeah,
contaminates a lot of things.
that's very well put. And imagining of psychological distress or psychiatric disorders as the anatomy, this is something which Freud used to do in psychoanalysis, because a lot
Yes.
of hydraulic and mechanical models of psychiatry and psychology that we would come across in psychodynamics.
Yes. Yeah. Yeah. And I think it's a helpful analogy for our patients too, because I was
Yeah,
trying to get across that sense in first responders. It's often not it's a vocational group that really deal in action, doesn't deal well. Often they're not particularly psychologically minded, if I was to generalize. So you have to give them practical,
yeah.
pragmatic ways of unpacking what they're feeling.
Yeah, and I also wanted to ask that what role does the culture play in moral injury?
I think it's a massive role, Divyam, and I think I almost feel ignorant talking to an international audience because we're incredibly isolated in Australia. Other than the part that immigration, it's a big deal to come to Australia. It's hours and hours and hours. It's not like we haven't got Europe up the road sort of thing, and culture's huge. Because culture also shapes our understanding of resilience, and certainly there's been plenty of examples of natural disasters. I mean, the tsunamis, 200 over 200,000 loss of life. Who can imagine what it was for a whole village to be wiped out, for whole bloodlines to be eradicated. So trauma is incredibly culturally informed, and often the expression and treatment of trauma is really almost a first world luxury. You're you are frozen. You're frozen. Um,
Yeah, I think we had some network issue, but we are ready to go.
Yeah.
So you're
I don't
saying
know if you caught the end. Yeah, sorry. Hello?
hello, can you hear me, Julie?
I can hear you. You're frozen, but I can hear you. Yeah.
Yes, I can hear you as well. We may continue.
I was just saying, in many respects, the recognition of trauma and the treatment of trauma is a luxury. It's almost a first world luxury, for many people across the world at any given time. That there is no time to even contemplate. So I think we also have to be, there needs to be gratitude in vocational groups and in workforces that we're able, even got the opportunity to treat and deal with trauma as a condition.
Yeah. I think Bhavya has one question. So over to Bhavya.
Dr. Julie, I would like to state a finding of the National Mental Health Survey here in India that the
Mm-hmm.
prevalence of PTSD is around 1%, which is way
Okay.
less than the global prevalence of around 6 to 8%. And
Yeah.
apart from the several reasons, one of the reasons is that the other comorbidities, which cause a diagnostic overshadowing, and that leads to PTSD not being the primary diagnosis. So, in
Mm-hmm.
your clinical practice, have you experienced the comorbidities leading to the underdiagnosis of PTSD as well?
Yeah, definitely. And they tend to sort of cluster, I suppose, with GAD and MDD. So the anxiety and the mood disorders, and of course all the concomitant, more somatic conditions. So chronic insomnia disorder. Men, there's often erectile dysfunction. So I think, and it's interesting if we look at the etiology of PTSD through the various DSMs. PTSD traditionally was under the anxiety disorders in the DSM, but I wonder, Divyam, if that's very much a cultural issue, because in places like Australia where PTSD as a workplace diagnosis means people are paid compensation or given paid time away from work, I bet that's a far higher diagnosis in countries where that's not the case, where so I think again that's probably that impact of culture on your the overshadowing of of secondary gain around diagnoses.
Right. Also, taking away from the moral injury part, what I could take away was that the moral injury is the psychological component of PTSD. And
Mm.
so I wanted to ask that therapies would work better for moral injury as compared to the hyperarousal, which will require the pharmacotherapeutic interventions. What are your
Think
thoughts on?
yeah, I think that's a reasonable way to approach it, but there's also that sense of, are we going down those sort of false dichotomies again of mind versus body, because if there's hyperarousability, you have to deal with that before you can do the talking therapies. And the example of the second case of the policeman, I mean, he had a very good psychologist. He'd been off work for a number of years. He had a very good psychologist. He just wasn't getting better, was because the physiological issues hadn't been dealt with. And they kind of all end up being entwined. And I think, by the time someone's not functional, so I think that sense of moral injury being psychological, but, there's always a psychological component to any psychiatric diagnosis, be it PTSD, be it schizophrenia, be it, do you know what I mean? Like that you can't just sort of neatly section them all off. And that's what I think the danger is at the moment, is the belief that moral injury can get better without there being medical oversight and intervention. I think it's a falsehood.
Right. Thank you, Dr. Julie. Now we'll be continuing with Dr. Divyam's questions further.
Thank you.
Yeah. So you have some time to spare, Julie. maybe like 5 more minutes.
Okay. Although if there's no more questions, Divya, maybe we should give people an early mark.
Yeah. So I was just saying that we will stop the recording, and then we'll have some informal talk for 5 more minutes. Is that okay?
Okay, that sounds wonderful.
Yeah.
Thank you.